Welcome back, everyone, to our Critical Care Symposium. We are at the final portion of our morning together. We have 2 more discussions to go. And to kick us off for this last session is an extremely talented colleague, Dr. Semhar Tewelde, who is currently an assistant professor with us here at the University of Maryland, who completed our UM-EM categorical residency program, followed by a fellowship in our emergency cardiology. And since that time, she has done an amazing job as faculty here with us in the Department of Emergency Medicine. Incredible bedside clinician, one of our nocturnists, and one of our cardiology gurus here on faculty, who is going to take us through some pearls. As I mentioned, heading into the break, we're going to shift from the RV to the LV. And Dr. Tewelde is going to bring us up to date, give us some key pearls and information on mending a broken heart, specifically dealing with cardiogenic shock. So, Semhar, thanks so much for joining us in this Critical Care Symposium. Really looking forward to hearing you over the course of the next 35 to 40 minutes.
Thank you so much for the introduction, Mike, and thank you for having me. Let's get started. I know Dr. Greenwood did a great job talking about the RV, and now we'll talk a little bit about the LV. I have no disclosures. For everyone joining us outside of the Baltimore area, welcome to the University of Maryland. This is our medical center here downtown. And for those that don't know, we are pretty historic. We are the first public medical school that opened in the United States, and it was founded in 1807. You may see the small highlighted red area, that is Davidge Hall. That was the first use of medical education at the University of Maryland. So as we're talking about history, let's get into cardiogenic shock. Cardiogenic shock was first coined in 1939, about a century or more after our medical school was founded. And it was founded by Harrison, and it was defined as a specific entity different from other forms of shock. Initially, the mortality rates were pretty dismal, about 80%. Over the next half a century or so, we identified that acute myocardial infarction is the primary reason people develop cardiogenic shock. After advancement in PCI, therapeutics, and the shock trial in 1999, we learned that early revascularization, predominantly early revascularization, is what decreased mortality rates. And currently, mortality rates have about halved. It's still a staggering number, and we have a mortality rate of about 30 to 40%. Now, we may be saying that's not that bad compared to 80%. However, that certainly is not great. And what is more concerning is over the last decade to 2 decades, we noticed that the cardiogenic shock rates are in fact climbing. And if you look here at this graph, we're looking at all comers with cardiogenic shock, specifically AMI or acute myocardial infarction cardiogenic shock, which is actually at the lowest of the totem pole here, you can see. And then in the middle again, non-AMI, which we'll discuss different entities. But hospitalizations over the last 2 decades have almost tripled. And so that is pretty alarming. I'd like to discuss a standardized approach for cardiogenic shock. And let me give a disclaimer here. Cardiogenic shock is complex and heterogeneous. So there's not going to be one bundle you can use for all patients. As Dr. Greenwood discussed, there's RV shock, RV failure. I'm going to discuss LV failure. There's biventricular failure, and there's multiple etiologies. But this is just a standard approach when seeing cardiogenic shock patients. So there's going to be 5 steps I want you to remember. First, we're going to discuss how to recognize cardiogenic shock, which is quite subtle in its nuances. It has various classifications and phenotypes. And of course, we'll discuss pathophysiology. Next, we'll discuss resuscitation. So we are all master resuscitationists, and we're going to basically discuss the ABCs. What are the ABCs when it comes to cardiogenic shock, and how can we best manage these patients? Then we're going to talk about, again, how to effectively decrease morbidity and mortality, which includes revascularization. We're going to briefly discuss recourse and what this means as mechanical support devices. And finally, we're going to talk about regionalization. What can we do to get patients better care when it comes to cardiogenic shock? And we've seen this with other time-dependent etiologies such as stroke or STEMI, setting up a lifeline network in which we basically have a hub and spoke model, and we divert patients to appropriate care centers. So let's begin with recognition. I think this is actually the meat of the talk and the most difficult thing. When we see patients in undifferentiated hypotension, specifically, you're wondering, is this hypovolemic? Is this septic or distributive? Is this, again, cardiogenic? Is it obstructive? And so how are we going to figure that out? Well, let's first discuss the pathophysiology. So cardiogenic shock is usually because of a primary cardiac insult. And what happens is it results in decreased cardiac output and hypotension. This then results in systemic perfusion being poor, and it also results in coronary perfusion being poor. This end result then ends up increasing your left ventricular end diastolic pressure, causing pulmonary congestion, causing hypoxia. And so they often come in with dyspnea and increased work of breathing. This furthermore causes a compensatory vasoconstrictive response. And we know that the systemic hypoperfusion in many people, about 20 to 30%, also causes a surge-like reaction. So you have inflammation that ensues, you have release of inflammatory mediators such as nitric oxide, interleukin, tumor necrosis factor. And so you have this spiral of death, as we call it. On one end, you have this primary cardiogenic insult, and on this other end, you have this inflammatory cascade. And again, not all patients will have this inflammatory cascade, but it's rather difficult when your patient comes in undifferentiated with hypotension to decide, is this purely one or the other? And often in caution, we may be antibiosing these patients in addition to providing other adjunctive measures, which we'll go through shortly. Now, what is the primary cardiac insult, you may ask? As you see here from this chart, there are numerous reasons that you can develop cardiogenic shock. The two leading reasons are going to be acute myocardial infarction, accounting for 40 to 50%, and then you're going to have acute on chronic heart failure. And as we have improved therapies in heart failure, you're seeing patients live much longer. And so this is going to be another large population of patients, about 30 to 40%. Not to negate all these other things, but again, each etiology should have specific tailored treatment to that etiology. Now, let's discuss the definition of cardiogenic shock. Now, when we look at the landmark trials that have been done, the SHOCK trial, the SHOCK 2 trial, the IMPRESS trial, the culprit shock trial, all that you can see on the slide here, what do we notice? It's very heterogeneous. The definitions do overlap to some extent, but most importantly, these definitions come from all, as you see underlined, acute myocardial infarction patients. These are patients that had AMI, then developed cardiogenic shock. And as we just discussed, the etiologies for cardiogenic shock are far more than that. Although this is a large amount of patients, it's not all patients. So should we be redefining cardiogenic shock? Not all patients may initially present hypotensive as you'd expect. And now even more into the definition, you have kind of two clinical parameters as you see to your left. You have clinical criteria, which we'll review, and then you have hemodynamic criteria. So what are those clinical criteria? Generally, again, patients are hypotensive, less than a systolic blood pressure of 90 millimeters of mercury, or a MAC change of 30 millimeters of mercury, meaning a decrease. And this should be for at least sustained 30 minutes, in addition to poor urine output less than 30 cc's per hour, and also increasing or rising lactate greater than 2. Now, when we talk about hemodynamics, most people that come into the emergency department are not going to have a pulmonary artery catheter placed initially. And there's controversial literature currently as to should we be placing these things. And I think based on the AHA recommendations in 2017, certainly when a patient is in the cardiac ICU or the medical ICU, and you have a person who is not responsive to initial therapy, that is when you should be considering putting a Swan-Ganz in. That being said, it doesn't mean we don't have surrogates to extrapolate when hemodynamics are poor. So again, when we talk about the definition, we're usually talking about a cardiac index less than 1.8 to 2.2, and that's dependent if you have vasoactive medications on. So without vasoactives, you're at 1.8, and with them, less than 2.2, pulmonary capillary wedge pressure greater than 15 to 18, and again, at increased CVP, at increased SRV, systemic vascular resistance, and an increased PVR, pulmonary vascular resistance. So again, we're not going to have these things at the bedside, but how can you identify your patients? I like to divide it into the three basic tenets here, which are systemic perfusion, pulmonary congestion, and systemic congestion. So what can we do? Ultimately, you can do a great physical exam on your patient. And how will those patients be different than other patients? I think the simple mantra is you remember these patients are usually cold. So they're going to have cold extremities. They have mottled skin. They typically have a poor cap refill. You may notice that they're delirious or have some altered mentation. Additionally, some other good bedside things using your vital signs is you can look at their shock index, right? You can also look to see what is their urine output. And then you're going to get some laboratory markers that are going to help assess assess systemic perfusion, specifically a lactate and SvCO2 if you have a central line, and so on. So these are the things that we are going to use as surrogates for your cardiac index. And just so we have nomenclature the same, cardiac index is basically your cardiac output, taking into account your total body surface area. When we talk about pulmonary capillary wedge pressure, now, how do we know a patient is congested? I think the best test is going to be your lung ultrasound. Point of care ultrasound is going to be key to your resuscitation in these patients. In addition to that, certainly some people may be tachypnic, dyspneic, have nasal flaring, be orthopnic, certainly, so sitting upright and tripoding. And then finally, systemic congestion. What are we going to look for? We're going to ask patients potentially about their weight gain. What is their dry weight and what are they today? We're going to look for pitting edema. You're going to look for hepatojugular reflex. You're going to look at your IVC. Two things that I didn't mention with systemic perfusion are, I think, very vital. It's looking at your pulse pressure. So noticing you're having a narrow pulse pressure is indicative of end-stage heart disease. And then pulsus alternans. For those that don't know, it means when you're checking your pulse, you usually have a patient that has an initial bounding pulse, and the next pulse is rather thready and weak. And this is also indicative of end-stage disease. Let's move on to another chart here from the 1970s, actually. This is the Diamond-Forrester chart. And if you see on the y-axis, you have systemic perfusion or cardiac index, and on the x-axis, you have your pulmonary capillary wedge pressure. And when we think about, again, this chart was derived when patients had acute MIs resulting in cardiogenic shock, but it has been extrapolated to patients now with acute on chronic heart failure. So when a person has a good cardiac index and they are dry and they have a low pulmonary capillary wedge pressure, they're compensated. The mortality numbers that you see listed there are in patients that had acute myocardial infarctions. When your patient comes in and is slightly decompensated, they have good perfusion, but yet they are congested. So a PWCP, so pulmonary capillary wedge pressure, greater than 15 to 18, they may be congested. And when you do your lung ultrasound, you may see B lines requiring diuresis potentially, and then pushing them back into this compensated box. Now, a patient that has more progressive heart failure may in fact now have a decreased cardiac index, and their wedge pressure may be low depending on if they have been taking their diuretics. Sometimes if they've been over diuresing or in fact have been having insensible losses, they may also be quite dry. These patients may in fact need a little bit of fluids, which is counterintuitive to a patient who has a low EF. But patients that are cold and dry, consider if you do a lung ultrasound and their lactate is up and they look dry, they may need small aliquots of fluid. Usually this should be no more than 250, maybe 500 cc's without reassessment, so they don't push over into the decompensated box. And these patients here are your classic cardiogenic shock patients. They have a low forward flow, so a low cardiac index, and their capillary wedge pressure is high. And in these patients, again, they have the highest mortality. The problem with these patients is if you try to diurese them, they enter the low flow box. So then their lactate will increase or their acute kidney injury will worsen. And if you then do the opposite and give them fluids, they'll become congested. And so these are the patients primarily here where you're going to need more critical care skills, including potentially vasoactive medications such as inopressors or inodilators, which we'll discuss shortly. So again, your classic cardiogenic box here is in the decompensated cold and wet box. That being said, it's not that easy. I want you to consider other phenotypes for cardiogenic shock. So now we're going to talk about, again, if you think that your cardiac index is high and your wedge pressure is low, this person can be defined as a vasodilatory shock. Earlier, we discussed that, again, after a primary cardiac insult, you can have this systemic inflammatory process that then vasodilates your bed, so it makes it a bit confusing. Those patients are quantified as a mixed shock. So they have some vasodilatory properties, they still have good forward flow, but they're congested. And these are considered cardiometabolic. And in fact, unlike the prior graph that I showed you, where your classic cardiogenic box, your cold and wet patient has the highest mortality, these patients here that have both a systemic inflammatory response and cardiogenic shock are even at worse prognosis. And so when it says cardiometabolic, what does it mean? Usually your heart is involved, your kidneys are involved, and your liver is involved. Now, if you have a person that has a low flow, again, and also a low capillary wedge pressure, we're talking about euvolemic or non-congested shock. These patients fare better amongst all three. And then finally, when you have that cold and wet patient, that's your classic cardiogenic shock patient, as we just discussed. Mortality there being slightly lower than your mixed cardiometabolic process. The data for these phenotypes were derived across 3 different international registries of over thousands of patients. And these are more novel concepts when we think about the nuances in cardiogenic shock. So resuscitation, this is something that we are masters at, and it's no different in any critically ill patient. You discussed the A, B, and C's. These patients are going to come in looking like this. They're going to have diffuse confluent B lines throughout all lung fields, and they should have a thin pleural lining to differentiate this from something like pulmonary fibrosis. And how do you treat these patients? No different than you would treat a patient that has heart failure. You want to put these patients on some non-invasive, especially if they're hypoxic and working to breathe. Sometimes this may be a temporizing measure, and you may need mechanical ventilation. However, you still should initially start with BiPAP. And let's discuss why that's important. BiPAP is going to decrease your preload. It's going to decrease your afterload. It's going to help with the hydrostatic forces and push the fluid out of the alveoli into the interstitial space and back into the circulation. And it's going to have less hemodynamic effects, certainly, than mechanical ventilation. In your patients that are truly shocky with altered mentation and having multi-organ dysfunction, you may need to use mechanical ventilation. That being said, what's most important is resuscitation prior to mechanical ventilation and optimizing these hypoxic patients for best first pass success. And so again, pulmonary unloading primarily is going to be BiPAP followed by mechanical ventilation when necessary. Often with early resuscitation, you may note that some people are able to be diverted and no longer require intubation, and understand that mechanical ventilation in these patients is very risky. Hemodynamic collapse often occurs, and so being ready for that is key. Let's talk a little bit about the RV. I know Dr. Greenwood did a great job talking about that, but the RV is a completely different circuit than the left ventricle. And so when we discuss what can we do to unload the RV, you can give medications such as inhaled nitric oxide or inhaled prostacyclins, ibuprostanol. And so this is going to help. That being said, don't forget, when you unload the RV, what inevitably ends up happening is that blood that's in the RV will push forward into the lungs and into the LV. And the problem is, if your patient is not already mechanically ventilated, it may cause worsening hypoxemia and work of breathing. So before you initiate RV unloading, make sure you consider that, especially in your tenuous patients. Let's move on to, so we've handled A and B, airway and breathing. Now let's talk about circulatory support. Circulatory support in a person like this with a low EF may require things like inopressors or inodilators, and that's going to depend on what your map is. I think the first important delineation here is, what are we using the medications for? An inopressor is going to be guided by your map, and making sure you have good systemic and coronary perfusion, whereas an inodilator is going to be titrated to your cardiac index. And don't forget, in these patients, we're saying we don't have a Swan-Ganz, so we need to consider what other surrogates we're looking at. I've highlighted here, if we talk about evidence and what's the best evidence, I would say that many people with undifferentiated shock would go towards norepinephrine. If you do happen to do a bedside echo and you note a reduced ejection fraction, you have some end-stage end organ issues such as increased lactic acidosis or AKI, pulmonary congestion, you may consider low-dose epinephrine, low dose again, that is going to give you some inotropy in addition to your pressor effect. Important to note that epinephrine compared to the inodilators, which we'll discuss shortly, is about 100 times as potent. Okay, again, there's a fine line though. Epinephrine does have other controversial effects, including increasing lactic acidosis. Okay, so norepinephrine is generally the go-to, especially in a person that we think has mixed shock. It's going to give you more of a pressor effect. That being said, the SVR is then going to increase, and so this may be difficult to balance in your cardiogenic shock patients where you want to lower the afterload. If starting norepinephrine, start at a low dose. If starting epinephrine, if starting epinephrine, start at a low dose. Inodilators again. When should we be using this? When we notice that the cardiac index is poor, and again, those surrogates are poor perfusion, meaning your skin is mottled, you're cold, you have bad urine output, your lactate is increasing, your renal function is increasing, you have shock liver, you may then require dobutamine or milrinone. When we talk about the differences between the two, again, evidence here does not place superiority or inferiority amongst them. They're just going to have different effects, and you need to know those. Dobutamine is much more titratable with a half-life of about 2 minutes or so. So you can turn it off and on much faster versus milrinone is a couple of hours. And a person with renal dysfunction, that is then worsened to 4 to 6 hours, in fact. Milrinone has other effects in the pulmonary circuit as opposed to dobutamine, meaning it will decrease your PVR a bit more. And so people that have primarily right ventricular dysfunction may fare better with milrinone. Milrinone also is a cyclic AMP agonist. And so in that case, if the person is beta blocked and you're worried about medications not working secondary to beta blockade, it may be your agent of choice. I would say in my practice, when I have had cardiogenic shock patients, I generally, if I feel like their MAP is not too low, and usually that's about 55 to 60, I may start with only epinephrine as an initial agent. If the MAP is below 55, I may start with norepinephrine and add dobutamine. Again, evidence here is based on consensus data and basically applying the best two for every phenotype in cardiogenic shock and not having a one standard approach for every patient. If we look at all these medications on this graph here, you notice that all of them have some positive inotropy, with norepinephrine being at the top with constrictor effect. And so again, it's going to affect your afterload the most, and so can be deleterious at times. So you need to weigh that with adding something with a vasodilatory effects. Revascularization, we know this is the cornerstone for therapy, and this is what's really affected mortality. So generally, when patients come in within the first 10 minutes, you want to make sure you're getting an ECG to assess for any ST elevation that needs to go immediately to the cath lab. NSTEMIs, non-ST elevation myocardial infarctions, also have a propensity to go into cardiogenic shock, so they should not be negated and still warrant urgent, if not emergent therapy, if they're actually in cardiogenic shock. And then finally, if you notice AV dysynchrony, meaning a person is either an AFib, very tachycardic, very bradycardic, you may in fact want to cardiovert or pace them accordingly. Often this will improve their shock status. In addition to using your ultrasound to look at B lines and EF, you want to consider color Doppler over your valves. And why is this important? As we saw in the very beginning, there are numerous etiologies for cardiogenic shock. Something as simple as valvular dysfunction, as you see here, MR, is something that can be easily missed. In fact, this is from a patient I had not long ago that was signed out to me. This patient came in quite hypertensive, looking like a typical congested, wet patient. He was put on BiPAP, he was started on a nitroglycerin drip, and in fact, he was waiting to be admitted to the cardiology IMC. And after we did color Doppler, we noticed that there was raging MR, and this person, in fact, then got diverted to cardiac surgery to have valve repair. And so this is important to say that if you're able to use your ultrasound to look for valvular issues emergently, that's quite important. And if not, it may be the time to order a stat echo. Mechanical complications include just chronic valve issues, or chordal rupture, papillary rupture, wall rupture, and ventricular septal rupture are more common with acute myocardial infarction. Let us consider recourse, and what exactly does this mean? This means that, let's say you're already using an inopressor and an inodilator, and a person is then not doing well, meaning their systemic perfusion is not improving, their mental status is not improving, you may have intubated them. This may be the time that you want to further augment their ventricle, and how can you do that? Certainly, there is a variety of mechanical support devices available that we should know. That being said, this decision is usually made in conjunction with cardiology, your intensivist, and your cardiac surgeon. When we look at different devices, it's important to understand these devices should be based on the phenotype of cardiogenic shock you have. So a person that has LV prominent shock, and here you're going to see at the top of your graph different parameters. And again, these require Swan-Ganz catheter. And so based on that and your hypoxemia, you may be looking at a percutaneous ventricular assist device versus something like ECMO or PVAD with an oxygenator. And we're going to review some of these devices shortly. Again, this is not important from the EM perspective, meaning in the ED, you probably will not be having these measurements. But if you have a patient that has acute on chronic heart failure that's been presenting several times and going down their ladder, meaning something we talk about is the Intermax score, they're worsening in their cardiac status. This is something to get on board early and not to wait until a person is necessarily upstairs, given the fact that you may want to transfer this patient to one of the hubs. So again, LV dominant cardiogenic shock, we look at certain devices, which we'll go over shortly. And here I'd just like to mention that, again, RV dominant shock versus biventricular shock, those are different. And I won't go into these parameters, basically just to say every phenotype is going to kind of be tailored with a different device. So what are these different devices? I think we know the intra-aortic balloon pump in its heyday was used often and is still, I think, quite often used after acute myocardial infarction. That being said, when you look at the amount of ventricular augmentation it provides, it's that 0.5 liters per minute. So quite nominal compared to other devices. The Impella and the tandem heart, as compared to VA ECMO, the big thing to note there is that your afterload is going to be increased with ECMO, and a person that already has poor EF, low flow is not going to do well with that. And so often they need some augmentation, whether that means venting. And now you may even see more studies are coming out with the use of Impella in addition to ECMO to augment the LV. What do these support devices do? They basically play different roles. They may be a bridge to your recovery. They may be a bridge to cardiac transplantation. And they may be a bridge to a permanent ventricular assist device. Let's talk about regionalization. What does that mean? That means, should we be having Lifeline or your EMS take patients who are presumptively in cardiogenic shock? Maybe they have a history of heart failure and they look even worse to your medics going to certain hospitals. And so there have been studies in Arizona, in New York, and even overseas in France, looking at this, even having go shock teams that go assess patients and decide if they need to be moved to the hub and spoke. So this is something that is a work in progress, and we're working on here in the States. More importantly, how can you have a common vocabulary that you use with your intensivist, your cardiologist? So this is the SCI classification, so the Society of Cardiovascular Angiography and Intervention. And they developed this classification to basically have a common jargon that we use when discussing patients with cardiogenic shock. So if you look here, you have a scale from A to E. So at risk, beginning, classic, deteriorating, and extremis. And here you have the different physiologic findings, meaning their physical exam, the biochemical markers, and your hemodynamics associated with each. And note, in the A category, you have patients who are not yet hypotensive. So again, this requires nuances in your physical exam, data history obtaining, and including all the etiologies to ensure that you're not waiting for a patient to become hemodynamically unstable before discussing them with your hub model. I don't think I have any time for questions, but I do think we will have time later. So let's review this 5-step approach. I'd like you to recognize that cardiogenic shock is complex, it's heterogeneous, it has various phenotypes, and it's not going to have a one-size-fits-all approach. However, I'd like you to note that resuscitation should be the ABCs for every patient. Echo is going to be vital in your resuscitation. Initiate BiPAP early to improve work of breathing. Consider mechanical ventilation when necessary, especially with multi-organ failure. When that is in mind, have caution because of hemodynamic collapse being possible with worsening the afterload and preload. Consider vasoactives. Initially, you may want to start with an inopressor if your MAP is quite low, or you can initiate an inodilator. Inodilators have been shown to improve hemodynamics. That being said, mortality is often worse the more catechol you add. So you only want to do this for a short period of time. Revascularize patients. In addition to that, look for other etiologies. Your echo is imperative there because you may find valvular dysfunction that warrants immediate surgery, or you may find an abscess or other things that can better be treated when early identification is possible. Recourse, consider temporary mechanical support devices, involve your cardiologists, intensivists, cardiothoracic surgeons, and recall that these things are only a bridge to different things being recovery, palliation, or a durable VAD. And finally, remember, regionalization is important. We are working on this currently, and consider what is your hub. If you're a spoke and at a tertiary, if you're at a hub model, if you're at a spoke and you don't have a tertiary care hospital close to you, get them involved early. Remember to utilize your SCI classification when discussing these patients. And hopefully in the coming decades, our mortality rate will go down even more. Thank you so much for having me.
All right. Well, thanks so much, Semhar. That was outstanding on what I think is an under-recognized component or category of shock in the emergency department. So you've given us really, really beneficial, really helpful information on how to resuscitate these incredibly, incredibly complex patients.